Okay, I thought you asked me to.
Pain rehabilitation programs are typically comprised of three main elements, these being mobilization or exercise, education, and instruction in self-management skills, sometimes with a medication management component. Really no different today than the program that I trained in 30 years ago. That's right, there's been little or no change in our approach to pain rehabilitation in the past 30 years. Now, that would not necessarily be a bad thing if we were doing a fabulous job, but we aren't doing a fabulous job. Typically, 100% of the patients in these programs have chronic pain when they're admitted, and 100% have chronic pain when they terminate. 100% are work disabled at admission, and 100% are work disabled at treatment termination. Now, no doubt one could find some dimensions where individuals show improvement, but whether the observed improvement is really meaningful is a question that's open to debate. This is a graph that shows the magnitude of the pain disability problem over the last 6 decades, the millions of work days lost each year due to pain. And what we see is an exponential rise in the magnitude of this problem in spite of all the medical resources that have been invested in the problem. And when a health problem worsens, the more that we try to treat it, it invites us to reflect on whether we might be inadvertently contributing to the state of the problem. Now, one aspect of the pain disability problem is that when people go off work for a pain condition, they're staying off work for longer and longer periods of time. We keep people off work for extended periods as we go chasing symptoms. We over-investigate pain with high-technology imaging tools and referrals to specialists. A study conducted by the Liberty Mutual Disability Research Center showed that a request for an MRI for a musculoskeletal problem triggered an average of 3 specialist referrals but had no effect on the pathway of care. And we must keep in mind that while patients are waiting for their specialist consult, the clock is ticking. After 3 months of work disability, there is only a 20% chance that the patient will ever return to work. After 6 months of work disability, there is a less than 10% chance that the patient will ever return to work. Now, we prescribe extended periods of sick leave, proceeding as if we believe that there's some kind of curative processes associated with being at home. Well, there aren't any. Being at home is associated with social isolation, increased financial dependency, increased financial uncertainty, stigma, and increased probability of developing a mental health problem. If we used this language to explain to our patient why we were recommending a period of work absence, would it sound like a rational treatment plan? Would we say to Jack, I know your back hurts, but what I would like to try first is to increase your social isolation, your financial dependency and insecurity. I would like to have others think more negatively about you, and I would like to have you feel worse about yourself. And let's see how that works, and we'll take it from there. By putting someone off work after the onset of a pain condition, we're trying to solve one problem by creating another problem. We put patients off work with not much of a plan about how we're going to get them back to work. We seem to proceed from the assumption that once symptoms abate, the patient will automatically find his or her way back to work. But research shows that symptom severity accounts for only about 10% of the variance in work disability. Once we create the work disability problem, it takes on a life of its own that's largely independent of underlying symptoms. The disabling nature of medications that we prescribe for pain is another issue that needs to be given greater consideration. A prescription of an opioid for a patient with a pain condition pretty much ensures that the patient will never return to work. And no doubt we're going to see the same thing with medicinal cannabinoids. We are seeing an increase in the use of cannabinoids for the treatment of pain, a substance with analgesic properties that are barely superior to aspirin, but 1,000 times more disabling. Jack is a bus driver that's been prescribed cannabis for his pain. Do you want him driving the bus that's taking your daughter to school? I believe that by making some changes to the manner in which we deal with musculoskeletal pain conditions, that we could reduce pain-related disability and associated costs by as much as 30%. Now, this is a complex problem, and the solutions will necessarily be complex, and they're also going to necessitate stakeholder collaboration at several levels. First, we need to make the practice community more aware of the relation between duration of work absence and the risk of permanent occupational disengagement. As well, our practitioners need to be more aware of the disabling effects of some of the medications that are prescribed for pain. Private rehabilitation services greatly outperform public sector services when it comes to occupational reintegration for individuals with pain conditions. And one of the reasons is that injury and disability insurance policies often have a mandatory participation clause. In other words, patients must participate in treatment to mitigate their losses. Now, this clause essentially incentivizes participation. And for the public sector, we need to reflect on different ways in which we could encourage or incentivize participation in occupational rehabilitation, even for individuals who believe that they are unable to work. We also need to bring more flexibility to the financial security net that we provide patients with debilitating health and mental health conditions. Many patients worry that they might be well enough to return to work today, but are concerned that they might experience a recurrence or exacerbation of symptoms months down the road and have to go through the whole process of applying for disability benefits again. In a trial that we conducted with the Social Security Administration in the US, participants were guaranteed that their disability claim would remain open for 2 years after they returned to work. This simple policy change made it possible for many participants to take a chance on returning to work. Similar policy changes might also make it possible for some of our patients with debilitating pain conditions to take a chance on going back to work. Now, all of the treatment programs that we've developed for individuals with chronic pain have return to work as their primary treatment objective. So why my focus on return to work and chronic pain? Well, return to work is the highest level of independence that can be offered to work-disabled individuals with pain, and I believe that all of our patients deserve an opportunity to achieve that. And some of our research also shows that if a patient does not return to work after a pain rehabilitation program, then 80% of the gains made in treatment are lost within 6 months. So return to work should not be considered the outcome of a successful rehabilitation program. It has to be part of a successful rehabilitation program. So the takeaway message is, we need to increase the awareness of our practitioners about the negative consequences of prolonged work absence. We need to increase the awareness of our practitioners about the debilitating effects of certain types of pain medications. We need to be looking at incentives for participation in occupational rehabilitation programs, and we need to have more flexible policies to foster greater engagement in return to work efforts. Thank you for your attention.